Good evening, everyone. Welcome to tonight's webinar. Tonight is Sunday, July 31st, 2022. My name is Dan Green. I'll be your host this evening. So tonight is the actual last night, if you will, of our Sunday only webinars. Starting tomorrow, I believe. If you give me 1 second, I'll confirm that. Excuse me. Starting tomorrow, the webinars will be nightly. I believe they will be Monday through, Monday, Tuesday, Wednesday. They'll be Monday through Wednesday starting tomorrow. Sunday through Wednesday starting tomorrow. So hopefully you guys will be able to dial in for those webinars as well. In fact, tomorrow we'll start structured case webinars, which will be every Monday and Wednesday, and then we will be doing cases from folks that sent in their case list on Tuesday and Sunday and Tuesdays. So tonight is the last case list construction webinar. So basically, we have a few folks on. If you guys have any questions, I'm not sure if you've submitted your list at this point. Hopefully you're getting close if you haven't submitted it. But if you have any questions in terms of how you should phrase things or how you should list a particular case, by all means, please just raise your hand. I'm happy to take live examples, and otherwise probably just use just give you guys some general pointers. So I'm going to take you guys off mute, or at least attempt to. I think the three of you are self-muted. If you want to take yourselves off. Thanks, Eden. Eden, do you have any questions? Have you submitted your list yet?
No, but I'm planning to on Monday, mainly because of my affidavit, which will be ready Monday. But a question that I do have is about abbreviations specifically. Like, I know that they gave us the list of what's accepted, but in certain situations, like TOLAC, for example, if I spelled that whole thing out, then I would honestly run out of room.
Yeah, that's a great question. So you can abbreviate things. They're not going to disallow your list for abbreviations. And I will tell you, I've looked at quite a few case lists, this year already. And, every now and again, somebody will use an abbreviation that I'm not familiar with. And even looking at the list and, doing a couple cases beyond, I just even still can't figure out what they were talking about. There was somebody that had some sort of pediatric exam on their list and they abbreviated it. And to this day, I have no idea what they were talking about. Things like endometrial biopsy, you can certainly abbreviate that. Bilateral, if you hit it, use a B and a /L, especially if it's a BL salpingectomy, they're going to know what that is. EMB, again, in all caps, endometrial biopsy. TOLAC, as you mentioned, perfectly reasonable to mention.
Okay.
So if it's something that, anybody could look at this, almost whether they're an OB or not, but really more so no matter where they're coming from in the country, if they could look at it and figure it out. So it's not something that's just local to, your hospital or your town. You're probably okay. Again, I would stick to the common things: TOLAC, EMB, bilateral. You can abbreviate TOA, things like that nobody's going to have scratch their head and go, "What is she talking about here?"
Okay. That's helpful. Thank you so much.
You're welcome. And again, even when I do these reviews, like I usually tell people if they typed out endometrial biopsy, just to put EMB with a colon, and try to be brief. Remember, one of the high-level messages I give everybody when looking at their lists, especially if they're excessively wordy, is they have to look at your list and 5 other lists after doing 6 hours of exams during the day. So if you've written a novel, it's really monotonous for them to get through. So complete where they could look at your list the night before and go, oh, that's what she was thinking. Like if you have a hysterectomy and it just says fibroid uterus. Again, I would encourage you to say not say, but list leiomyomatous uterus. But, putting some semblance of the size, either clinical, so, 18-week size, or, you put ultrasound, US, colon, uterus, 15 centimeters, just some idea of what you encountered when you were making your decision, for example, about type of hysterectomy you're going to perform. It's helpful for them to look at and go, okay, this is what she was thinking. This is why she didn't start out vaginally, as an example. Does that make sense?
Yes, it does. Thank you.
Thank you. So Jonathan or Chioma, do either of you have any questions? I think you're self-muted, so if you want to take yourself off mute, please feel free. Jonathan, go ahead.
No questions. I'm just awaiting one affidavit. Hopefully it'll be here tomorrow.
Okay. All right, very good. What was I going to tell you? A couple just general things. And Carla, I think I've enabled you if you want to take yourself off mute if you have any questions. We're talking about caseless construction. So do you have any questions, Carla? Any specific cases you're worried about, question-wise?
Let me see specifically. Just simple things. I think, like some people say, don't write vacuum-assisted vaginal delivery, just write operative delivery. I think at this point it's just kind of nitpicky things like that. Do you have any preferences or anything like that?
Yes. So, I mean, I usually do suggest people list the type of operative delivery they do. Okay. Just because, I mean, look, there's two choices. It's either a vacuum or forceps. Exactly. If I know somebody's doing vacuum, I mean, regardless, I'm going to ask you about both. So I'm going to, ask you the pros and cons of vacuum versus forceps and vice versa. Okay. But, so you want to, but you bring up a good point in a bigger context, Carla. Generally speaking, I suggest people to be less specific in terms of on their list. So any of you guys that are listening tonight, if you have a patient with a postpartum hemorrhage, I would so much rather you put either postpartum hemorrhage management or uterotonics. And then if you have to use a Bakri balloon, let's say, you might put uterotonics, tamponade, and then tamponade device. But if you list every single thing you did, like if you list the Methergin, 0.2 milligrams, or even if you just say Methergin, Hemabate, and Cytotec, it takes away from the questions that the examiner can ask you, because they're not going to say, well, what uterotonics do you use? Because it's sitting there right in front of them in black and white. Right. So, trying to roll things up, to a higher level is really preferred. So, if you have a diabetic patient, or let's say you have a hypertensive patient, a chronic hypertensive patient, sometimes people put, baseline preeclamptic labs, EKG, serial growth scans, antenatal surveillance, or sometimes they'll even actually put the NS modified BPP, starting at 32 weeks, and they start listing all this stuff. Well, again, that takes away questions that the examiner can ask you. So I usually suggest people say something like hypertension management, which could include everything I just mentioned. It could, and again, I'm kind of talking to you, Carla, but I'm talking to everybody. So, but it could include, it could include everything we just talked about. It could also include aspirin treatment, or you could list the aspirin separately. The point is, you kind of roll it up into one package. Yes, it's a little bit more for you to remember, but again, it promotes questioning, and these are basic questions which you have to know anyway.
Okay, thank you. One more question.
Sure.
Under postpartum patient, for a patient that, an OB patient that had thrombocytopenia, in the antepartum phase, you assume it's gestational thrombocytopenia if it's in the third trimester, less than 150 K. So would it be wrong, because technically you can't diagnose that till 12 weeks till it resolves, to write that in the antepartum? Should you just leave it generic as thrombocytopenia?
Yeah, I think you could, if the patient doesn't have a history of thrombocytopenia before pregnancy, I would list it as gestational thrombocytopenia. I think you're on solid footing to do that.
Excellent, thank you.
Sure. And you bring up another thing that just kind of triggered something in my mind and memory. I've looked at a couple lists in the past few days where people put things like mild gestational thrombocytopenia or endometrial hyperplasia with focal atypia. Now, I understand that the focal atypia example might be what the pathologist reported, but the point is, and again, this is general, this isn't specifically directed to you, Carla, but the point is, words like that, they just take up space, because if you tell me somebody, for example, has mild gestational thrombocytopenia, that's great, but I don't really, this is going to sound terrible, but I don't really care that they do or they don't have mild gestational thrombocytopenia. If we're going to get into the subject of gestational thrombocytopenia, we're going to talk about kind of all different levels of it. So, what are critical levels for regional anesthesia? What are critical levels for if you have to operate on the patient? And what are levels that you'd be concerned with for spontaneous bleeding? So those levels are obviously much lower than than what we would construe as mild. But what I'm getting at is qualifiers like that don't really don't really help the situation. Like the focal atypia. Do we care that it's focal atypia? I mean, when we look at pathology from the endometrium, we're going to look at even if there's only one tiny area that's really bad, that's the diagnosis we're going with. We're not going to say, oh, well, she's probably just got, benign endometrial hyperplasia in that one tiny little area. We'd have no way of knowing where that tiny little area is anyway. So we would treat her as if she's got EIN, which in fact that patient does. So I guess what I'm getting at is be careful with the qualifiers. I've seen a lot of focals recently, a leaf specimen with positive margins, and the candidate put, focal margin or focal margin, focal area positive for CIN3, on the margin. And it's like, okay, she's got positive margins. It really doesn't matter. And to that end, when you're proofreading your list, and again, when I say proofreading it, I'm talking about, not only completeness, but it's sometimes too much. Like on the office list, people will put, under breast disease, they'll put 2 centimeter mass, 2 o'clock position relative to the nipple, or 3 centimeters from the nipple. Remember, guys, and they do that sometimes also on colposcopy. They'll say, biopsy at 6 o'clock. Remember, they're not going behind you to examine the patient or do a repeat colpo or anything like that. It doesn't really matter where the lesion is. It does for your notes, of course, but it doesn't matter in terms of, your management for the patient. So those things just take up space, and they serve really very little purpose. And again, we're trying to have our list, complete but succinct. So it looks like, Daniel, it looks like you've joined us. I'm going to unmute you. I'm trying to unmute everybody. So you can unmute yourselves as you wish to speak, but did you have any questions or cases that you're concerned about? How to list them? Damn, you get him. I'll assume not, Daniel. Chioma, anything that you were concerned about?
No, thank you.
Sure. So I'm not sure if any of you guys are going to be submitting second submission, and I'm certainly not necessarily suggesting it, but again, I would encourage you to try to proofread your list, to try to make it, pare it down. I'm going to show you in a second. I'm going to share my screen here and show you guys kind of an example of too verbose of a list. So hopefully you can see this. Try to make it a little bit bigger. You can see that this particular candidate kind of wrote a novel. Now, I know you guys are limited. This is a little bit of an older case list, and I know you all are limited by the number of characters you can include. But you can see, abdominal pain, fever and chills, postmenopausal status, suspected early appendicitis, admitted by general surgery, no response to antibiotics. I mean, it's like a whole. It's almost like what you'd see in a history and physical, as opposed to just kind of the highlights. So they are going to expect that you are able to fill in details for patients. So in that vein, not necessarily list every single thing that the patient had. I mean, if you look at this, it says suspect bilateral tubovarian abscesses, neoplasm, ovarian neoplasm, endometrioma, large hemorrhagic cyst. I mean, holy cow. They gave the whole differential. They gave in full sentences almost, kind of what happened with the patient. So this is an example of really a poor listing of a case. So again, hopefully, and you can see there's multiple diagnoses running across the lines, which in turn makes it difficult to read and difficult to follow. In general, to the extent that you can, if you haven't put like a hyphen or something before each diagnosis, hopefully you have like one diagnosis per line, so it's much more readable. But when they kind of morph into and carry over to the subsequent lines, it's one thing if something takes more than one line, but I wouldn't expect you to start another diagnosis on that same line. I would expect you to, wherever the first one ends, start with a completely new line. Same thing for treatment. And from a GYN standpoint, anything that you kind of do in the office beforehand, so if you're doing an endometrial biopsy in the office, even that would go under your pre-op workup. Failed medical management, even though that's a treatment, really would go under your pre-op workup. Your treatment would be the surgery, or in the case of an admission, you might just, list the admission and the IV antibiotics and what have you, if it's a medical admission. But otherwise, all the other stuff should go in the pre-op diagnosis. If you have a patient that has fibroids, let's say she's got small fibroids, something around 150 grams, you want it to be clear why you did the hysterectomy on the patient. So, it's not good enough the patient has fibroids and heavy bleeding. She may want definitive treatment. She may have failed medical management. All these things are, buzzwords that you can put in to kind of help explain why you ended up doing the surgery you did. A couple other things I'm going to mention to you guys on your OB list for your Gravida and Parity. I would encourage you guys, the parity should not increase by the recent delivery. So in other words, if somebody is pregnant, let's say she's pregnant, she delivers vaginally, so she, let's say even full term, baby's well, on your list, she should be let's say she's never been pregnant before, she'd be a G1 P0. A lot of times I'm seeing folks put that patient as a G1 P1. So they're actually counting the delivery at the right at the time. Generally speaking, the delivery that just occurred should count in the patient's Gravida, but not in the Parity. So not sure how you guys have listed that, but would encourage you to check that. For patients that have had prior C-sections, very important to list prior CD times however many. And if you offered them Tolac, it's important to put declined Tolac if they declined it. Consistency on your list, guys, is critical. So if you're putting declined Tolac, it should be on there for every patient that you actually offered it. Similarly, endometrial biopsies. All your ablations must have an endometrial biopsy before you did the ablation. The only exception would be if you couldn't do one, and then technically you should have done a DNC, perhaps with a frozen section before doing the ablation, because the question comes up, what if you ablate this patient and she comes back with benign endometrial hyperplasia? How are you going to manage that? So let me pause here and see if anybody has any questions. Anything, guys?
I have a question. This is Eden.
Uh-huh.
So
Okay.
half of my OB list is AMA. So should I put AMA on the problem list for half of my patients, even though it's obvious with their age? Just, if I'm going to put it on one, I have to put it on all of them.
So you're probably not going to like my answer, but I would put it. The whole thing is, if you don't put it, the question is, did you not put it because you just didn't put it, or did you not put it because you didn't necessarily recognize it, or maybe she was only 35, so you're like, she's 35, whatever, because, it's almost like you want to, and taking what your question one step further, not only would you want to list the AMA, but you would want to list that either some form of genetic something. So either she had an amnio, in which case I'd list amnio and nothing else, because the counseling would be implicit before she had the amnio. If she had CVS, I'd list that and nothing else. Or genetic counseling if she refused all other testing, or genetic counseling declined. But it's almost like, okay, I've got this complication in the antepartum, and here's my one-to-one what I did about it in my procedure treatment column. So I am a believer in that, because if you think about it, there's the genetic aspect, but then with AMA, we're talking about, do you do any increased antenatal surveillance on your AMA patients? If so, what and when? Does it affect the timing of your delivery? So in other words, would you let a 40-year-old go beyond 40 weeks, as an example? So there's,
Okay, that makes
it
sense.
promotes questions, and there's more stuff a little bit with it than just the genetics.
Thank you.
Oh, thank you. Good question. Anybody else have any questions? Because I'm otherwise going to go back to
I have a question.
talking about it. Please, save me.
So,
Carla.
hi. So, Shamrock had mentioned on a couple of them, like for example, G5P2, to kind of just recognize, obviously, if someone had 3 spontaneous abortions or 2 terminations, things like that. I don't have it written like SAB times 2 on each and every single person. Is that something that you find important, or just something like if they bring up, you could address?
Yeah, the latter. In fact, when people start putting, prior, SAB times 2, whatever, I always tell them to eliminate it. Now, look, if somebody has a history of recurrent miscarriage, you might say recurrent miscarriage, but the point is, when there's a gravidoparity mismatch of 3 or more, that line of questioning is fair game, even though she may have had 3 abortions. It kind of doesn't matter, because once the question's out there that they ask you, it doesn't matter that they were terminations or they were miscarriages or what have you. So yeah, that would be too detailed to list, 2 SABs, 1 whatever.
Okay. And then another question, I have this one patient, doesn't really have like super important antepartum history. She did have a history of a 3rd-degree laceration, so I was just going to write that to spark up conversation because I don't have a 3rd-degree laceration. But do you think that's fine to just add that as and just put counseling, because I did counseling.
Yeah, no, I think that's fine. Certainly you can list that. Things I tell people usually not to list would be like if you had a patient with a low-lying placenta that resolved, obviously before delivery, and let's say it didn't affect anything other than you got 1 or 2 ultrasounds during the course of the pregnancy. It's not like she was admitted for bleeding or anything like that. Things like that I've been telling people just to leave off, because it doesn't really add anything. So, and things that are really out there from previous histories, that aren't necessarily relevant. I mean, history of gestational diabetes, that's obviously relevant. Patient had a history of preeclampsia, that's relevant because you're going to put her on aspirin. But, certain things like history of postpartum hemorrhage, so it's relevant for you to know, but if the patient didn't end up having a postpartum hemorrhage with this pregnancy, it's like, so what does that mean? That means you had, uterotonics available, most likely, right?
Yes, that makes
Carla,
sense.
you still with me?
Yes, that
Yeah,
makes
so that, if she had a postpartum hemorrhage with this pregnancy as well, totally different ballgame. You want to list the history of the postpartum hemorrhage in a prior pregnancy, by all means. But there's certain things that okay, I was prepared for this, but I didn't end up having to do it.
Okay.
And they're judgment calls. But you in the end, I always tell people to take a copy of their list after you your final list. Not that you'll take into the room with you when you do your Zoom test, but take a copy of the list, put the pertinent positives and important negatives in the margin, and that way you can practice from it. People sometimes put on their list, arrest of dilation or arrest of labor or 8 centimeters. I always tell them to eliminate the 8 centimeters as an example, because who cares? If she's in active labor, whether she's 6, whether she's 7, whether she's 8, it really doesn't matter. It's an arrest of active labor, assuming she meets the definition. So things like that are also places where you can, trim down the list, because in the end, they're not going to say, well, was this patient 7? You're going to go, oh, I don't remember. She might have been 8. Who cares? Your treatment is going to be the same. So that's the kind of stuff, again, from a judgment standpoint, I would suggest you guys consider.
Okay.
Great. Thanks, Carla. I know I expanded way more on your on your question, but I'm kind of trying to cover things because some people will actually listen to this recording after the fact. So trying to be as complete as we can.
Okay, another question for you. So I've heard multiple things on this.
Thank you.
You're welcome. On the actual, for example, the office practice list, you know how it says number of visits per the practice or the bulletin, it says, however many visits you saw this patient from whatever it is, June 30th to July. So if, let's say, I saw a patient, an OB pregnant patient that had dysuria, then I did a UA, whatever. And so I've seen her for a total of 7 visits at that point. So I've heard 2 different trains of thought that you should just put the visit that's pertinent to what the complaint was versus, as the bulletin says, the total number.
Yeah, so that's a great question. So if you had a patient that you were, let's say, was, some sort of management of, let's say you were taking care of her for prenatal care, as you said, in pregnancy, I would list all the prenatal visits. If you saw her, let's say, 6 months after delivery because she had a yeast infection, I would not count that visit. Again, I would count the visits that pertain to the issue at hand, but the issue at hand could be pregnancy in general. It might be, as you said, a UTI in pregnancy, but that's still pregnancy in general. Again, if she had a completely different problem outside of pregnancy, abnormal uterine bleeding 9 months later, again, I would not count that visit.
Okay, thank you.
Sure. By the way, again, just speaking in complete non sequiturs tonight, I'm not sure how many of you guys have thickened endometrium for your patients that are not menopausal. So if you have a chance to peruse your list one last time before you all submit it, please don't put thickened endometrium for a non-menopausal patient. It really is meaningless. I understand the pathologists report it that way, but for your non-menopausal patients, we're really only concerned if the patient has heterogeneous or homogeneous endometrial lining. So there is no absolute abnormal number for a non-menopausal patient. So again, you might want to scan your list, scan your list for that. And of course, as long as we're talking about general rules, make sure you haven't listed a patient more than one time anywhere across all 3 lists. So not once per list, but anywhere one time across all 3 lists. So if you consider all 100 and however many cases you have, they can only be one of those 100 and some patients that you reported. Let's see. Make sure you know your definitions well. This kind of bleeds over a little bit more into the course, but I have seen people that have put arrest of labor, failed induction, and those, as you can imagine, are mutually exclusive. And so if you put it down in writing, if they're glancing at your list the night before, they're going to go, he or she doesn't even know the definitions of these terms. And not that they're going to necessarily fail you based on that, but it starts to paint a picture of doubt in the examiner's mind. And so the next day, unless you're really firing on all cylinders, they're going to perhaps walk into the exam with a less, I don't mean literally just for that one oops, but they're going to walk in, with a less than neutral opinion of you. And that's same thing with this list that I've got showing you in the background. I mean, you can imagine if you have to read all this compared to what most people put on their list, it's like, what's going on here? This person's kind of clueless. Let's see. What else? So, if you have a patient that had 2 procedures, if they're an OB patient and they have to be listed on your OB list, so in other words, they're not between 39 and 41 weeks, completely uncomplicated delivery. So there's somebody you actually have to mention on your list. You might put, 6 months postpartum, DNC for abnormal uterine bleeding or something along those lines. So you've accounted for the patient, but you haven't listed her more than one time. Also, feel free, if you did not do the particular procedure or readmission, if you have a patient that comes back 3 days after she's discharged with preeclampsia with severe features, let's say your partner does the admission, you can put postpartum day 7, readmit with preeclampsia with severe features times 2 days, and then in parentheses you put by partner or by colleague. So again, it's not getting you off the hook or anything like that. It's just being kind of upfront with the examiners. Similarly, you can do that for certain GYN cases if they did part of the surgery. When I say part of the surgery, I'm talking about like you did a hysterectomy and they did a sling, for example. Or if somebody had a complication of a bowel injury, and was admitted when your partner was on call that weekend, and maybe they went to the OR with the general surgeon. Again, you might list it with with the partner. For those of you that dialed in last time, I'm sure you heard me say, please make sure when you're doing your office list, and again, I know you've already done it, you're probably like super sick of it, but one more quick scan before you send it in. Please make sure you haven't selected the most unusual and interesting case you can possibly fathom, because if you're going to have to spend hours studying about that to prepare for the chance that they may or may not ask you that, it's not worth having on your list. You kind of want the bread and butter stuff. I'm not saying you want to have 40 yeast infections on your list, but because you want to have some variety, but at the same time, you don't want to have anything that's so esoteric that you're really going to have to spend a lot of time learning about. Every year, people that don't have their list reviewed, at one of the courses we're doing a mock oral, and I'll ask them about it, and they're like, oh, I haven't prepared for that yet. And it's like, oh, I can't believe I put that on my list. I wish I had, had not listed that particular patient. So just remember, sometimes people look for the most unusual case because they think it'll be interesting for the examiner, which it may be. And remember, the examiner doesn't have to know anything about the case. All they have to, not about the case, about the topic for that matter. All they have to know is if what you're saying is making sense, or if it sounds like a bunch of horse hockey. So again, would suggest trying to stick to the more common things. I wouldn't put, for example, ambiguous genitalia on my list unless I'm a pediatric gynecologist. Similarly, wouldn't put primary amenorrhea. That's me personally. You might be a primary amenorrhea aficionado, in which case go to town with it, but that would be just a couple suggestions. What else? Obviously, you'll make sure your list has 40 office patients, not 39 and not 41. To the extent on your office section, you cannot have 2 yeast infections under vaginal disease, but maybe 1 yeast infection and 1 trick or BV. That would be preferred because, again, they're not going to ask you about both of those, but what they might do is they might ask, it gives them a better chance to ask about to ask about a patient that comes from that category. So again, variety. Same thing like 2 patients that are 25 for an annual well woman. Better to have a 25-year-old and a 55-year-old. And in that same context, if you have annual well woman for a patient, even if she's under, well, let's say she's under breast disease and you have annual well woman, and let's say either the mammogram came back abnormal or you felt something on the exam. If you put annual exam on there, you're still encumbered by all the stuff that's included in an annual exam, which would include age-appropriate screening and age-appropriate counseling. So you'd still need to know how much calcium and vitamin D, how much or which vaccinations, and I don't mean just the GYN vaccines. I mean all the vaccinations which would be relevant for the patient. If you have any patients that you saw in the emergency room, you can count them, but you don't have to count them unless you did a procedure on them. But if you saw somebody for an ovarian cyst and she had some pain, but she went home and you gave her NSAIDs and let's say birth control pills, and that was the extent of it, that's not a patient you necessarily have to list. Similarly, hospital consults that are not in the operating room, you don't necessarily need to list those as well either. Again, remember to try to be consistent. And one thing, and this is fresh in my mind because I was doing a case list earlier today. The person's list actually wasn't bad, but I'm sure she went to an exam pro course or something, and they talked about use of capitalization, use of exclamation points. So if you have any punctuation on your list, that's fine, like an exclamation point for something unusual, but not like every other case. It really becomes monotonous, and I don't think it endears yourself to the examiner. An example when to use an exclamation point. Let's say you're operating on a patient that has an 8-centimeter adnexal mass, and let's say you do a laparoscopy, and she's got pelvic pain, let's say. So you do a laparoscopy and you don't see this 8-centimeter mass. So if you're reporting your gross findings, no mass seen, exclamation point. That's fair enough. But a patient has postmenopausal bleeding and she's obese, and you do a DNC hysteroscopy and the tissue comes back showing benign endometrial hyperplasia or maybe even EIN, that would not garner an exclamation point because she's postmenopausal bleeding, so she's at risk. She's got another risk factor of being obese. I'm not saying it's a slam dunk that she's got hyperplasia, but it's not super unexpected either. So please try to limit your use of punctuation and also capitalization, trying to draw attention to a particular case. It really should be something unusual. So let me pause and take a breath. Anybody have any other questions or in general about the boards? Do you all have I assume you all have your dates already?
Yes.
Okay. Those of you in October, which is the first time they've ever done them this early in the year, your last thing you're going to want to hear is, start studying for your test. But to be honest with you, once you send your list in, by the middle of August, you're talking about maximum at that point 2 months to study. And let's face it, you've got practices and everything else, family obligations. So you're really going to want to start getting to it for those October folks by the middle of the month. It's kind of weird because we've never had it where you're submitting the list and almost immediately you've got to start studying. So I guess they'll find out this year whether it's good or bad. Anybody started studying yet?
No, I feel like the case list took up so much time.
One thing you'll want to look at, Eden, and this is for the rest of you guys too, take a look at the Pearls of Excellence.
Yeah.
I'm not saying you have to read everyone, but you'll want to peruse the titles and make sure you feel comfortable talking about, at least for the past 2 or 3 years, the titles that are listed. I've been told in the past that they've gotten exam questions. Actually, people that had trouble with oral exam questions, those questions turned into Pearls of Excellence, is what I've been told in the past. I don't know if that's still true. So, just a friendly suggestion. Anybody else have any questions, either case list or anything in your preparation for the exam?
I have a question about the actual day. Can you just tell us what you expect in terms of, timing and basically format of the exam, and if you have any suggestions on where we should actually be taking it, like in a library? Obviously, we wouldn't do it in like a coffee shop, but and then basic attire, I would assume, is formal wear, like it would be in person. If there's anything else you can elaborate on.
Yeah, so a little bit of this is speculation. Obviously, they did it virtually last year. there is some experience and some of your friends may be able to help you. I would definitely try to look professional. From what I understand, in the people that I talked to after, everybody took it from a room in their house. I mean, you're not going to want to take it anywhere probably but that. I mean, I know that in the past people had to remove pictures from the wall, like they couldn't have their diplomas up behind them or anything like that. And you'll want to make sure you have a good internet connection. They'll talk to you about this, or they'll send out information about it if they haven't already. But the good internet connection, you'll want to make sure that you have a proper pair of headphones that, you're not fading in and out. I've done mock orals with people on Zoom, and sometimes, they'll break up a little bit, or they're using their computer audio, and they're, maybe an extra foot away from the mic, and it's really hard to hear them. So you'll want to do some sort of practice. I'm not saying, you have to do a mock oral or whatever, but if nothing else, make sure you communicate with one of your friends, with a family member or something, using the setup and mimicking the setup that you're going to use when you actually go to take the test, because you don't want to find out you're having any kind of computer issue, obviously right before the test. You're going to be nervous to begin with. So look professional. You cannot have your telephone anywhere near with you. Last year, somebody actually, I think on the break or something, stepped out of the room. They brought their phone back, and they didn't have it like right on their desk or anything. This is as I'm told. It was off to the side, sitting on a table or something, but it was seen by the examiners, and they let them test, and then they failed them. And they failed them because of the phone. It wasn't like the person failed anyway. So please make sure that you do not have your phone in the room at all with you. I think I told you about the pictures on the back of the wall. Things you won't want to indicate is like where you're talking to them from. When I say that, I don't mean like, oh, I'm talking to you from my office study or whatever. I mean like, I'm in St. Louis as an example. So we never want to mention anything geographically to the examiner. Obviously, you'll have the 3 sections. You'll have the 2 examiners. They'll be on the screen. There is something that they do, I think, to kind of check your case list, but I'm not sure exactly what that is, whether they have you hold it up or what. One good thing that I was told last year that would not normally happen if you were going to be in Dallas, when I took it, we could take our whole case list in with us. They would thumb through it to make sure there were no stray marks, but we had the whole list, so it was a little bit easier from a context standpoint. In the past, what they've done is they've taken a snippet of your list. So let's say, this case that's displayed on the list, they would display it on the computer for you. But what you would see is you see the 4 boxes like you entered using their software. So it was hard for people. I'm told that you can actually have your whole case list with you when you're doing it by Zoom. So that is a good thing, because at least you'll be able to see that, oh, it's this patient, not that patient kind of thing.
Okay, so you'd recommend printing it out in advance so we can refer to it if they ask us a question, if they don't post it on the screen?
Yes, and again, you'll want to confirm with them. They'll give you the ground rules, but I'm fairly certain that they will, at least they did, allow people to have their case list, and it is helpful to have a printed copy. Because I don't know that you'll necessarily be able to scroll through it, on your computer when they're asking you questions.
Okay, all right, thank you so much.
Sure, I think you can also have pen and paper in there, which for me, I know when I get nervous, sometimes I forget what we're talking about. So I would, jot down like, okay, differential for, dysmenorrhea or something. So if I'm getting into the weeds about something, I can refocus myself and not go, what were we talking about again? That kind of thing. But they should provide you more instructions as you get closer. And again, they do want to make sure, they'll want to make sure your internet speed is up to a certain level or something. So if you're out in a rural area, you want to be cognizant of that. But definitely check out your hardware before the test day. Thanks for the question.
Yeah, thank you so much.
Sure. Anybody else have any questions? Eden, did you have something you were going to say?
No, I don't think so. You just answered a lot of my questions that I had.
Okay, well, I don't think I have any more words of wisdom as far as the case lists go, and it sounds like you guys have all pretty much finished your list anyway. But let's just see real quick. So we talked about consistency, and then there's certain things you can leave off your list too. And again, I kind of hate to keep going back to the list because I know you guys are almost finished with it. But you know, if a CT or MRI was ordered by, let's say, the primary care provider, and let's say it didn't really add any useful information, and if you had been managing the patient from the get-go, you wouldn't have gotten it. Those are things sometimes you can also leave off. Like sometimes, you know, somebody will have a small cyst and the referring physician will have gotten, you know, 5 tumor markers, but if you'd seen the patient, you wouldn't have gotten any. That might be something I would consider leaving off the list because, I mean, let's face it, if you have a 30-year-old, she's got a 4-centimeter cyst, you know, are you necessarily going to get tumor markers on it? I mean, unless she's got like massive ascites or there's, you know, it's super complex or solid, you know, or there's other features that are going to be concerning, you know, about the cyst. Generally speaking, we wouldn't get tumor markers as an example there. So you have to be careful about, you know, overutilization of medical resources. I saw somebody's list, they'd gotten a sonogram, this is for a polyp. They'd gotten a a fibroid. They'd gotten a sonogram, they got an MRI. I'm trying to think if they had something else. They did a biopsy in the office. Or no. They did a diagnostic hysteroscopy in the office. Then they took them for a DNC hysteroscopy. So there was all that stuff to take out a submucosal myoma. I was like, yikes. It seems a little over the top for one myoma. A list I looked at today, the candidate looked halfway decent, but she had a ton of BSOs for no apparent pathology on patients in their early to mid 40s or even late 40s, but, you know, definitely premenopausal. And, you know, you have to be prepared if you have stuff like that on your list, that those are the kind of things that they're going to focus on. You know, why are you doing all these BSOs on premenopausal patients, you know, without a clear indication? Let's see. I think that's pretty much it. Go ahead.
One more abbreviation question. Do you think AUB is acceptable for abnormal uterine bleeding?
Absolutely.
Okay.
And I think you can say PAP for PAP. And by the way, if any of you have PAP smears listed all over for your hysterectomies, I usually tell people not to list the PAP smear, that we're going to assume it's normal. The only time to list PAP smears, obviously, if you're doing a LEAP or cone, that's a whole different story, or if it's on your office list under abnormal cytology, whatever. But for your GYN list, the only time to list it is if you're doing a supracervical hysterectomy, or if the patient let's say you do a TLH for a patient with AUB and fibroids, and let's say the cervix comes back showing, you know, CIN 2 to 3. You know, even though it's not cancer and hopefully the margins are clear and everything else, you know, then I would list the normal Pap smear. But barring something like that, you know, don't list the Pap smear for every single case. It's not needed. Well, the candidate, they're going to assume that the Pap was normal unless you tell them otherwise. And your pathologies don't need to be novels either. So I've seen people, again, they take it right off the pathology sheet. So I understand where they're coming from, but it'll say like, you know, cervix, chronic cervicitis with squamous metaplasia. It's like, who cares? You know, the old KISS principle, keep it simple, silly. So, you know, try to keep it as short as you can. Cervix is benign. That's really all we would need to list for something like that. Guys, we're coming up on 9:20, so I'm going to give a last shout for any questions you guys have about anything. I'll try to answer it. Will be a case list or anything else as you start to prepare for your exam. And then next time we speak, it'll be for case list reviews. But tomorrow night, I think, is structured cases. Anybody have any questions, any last minute questions before we wrap up? You can also raise your hand if you're trying to get off mute and for whatever reason you can't get off mute. Okay, well, I don't think I'm going to take the last couple minutes of just wasting your time. I've really pretty much came up, unless you guys want to see other case lists. I can show you some more case lists if you have any interest in that. Anybody have any interest in that? Here's an example of the punctuation. You guys can see down here. This patient was found to have a perforated IUD. It was discovered during an appendectomy. Wow. You know, okay. Not super exciting, right? Here's a common mistake we find on patient number 14. She's AMA and gestational diabetes, says increased fetal surveillance, routine diabetic care, like that, glyburide, oxytocin. What's missing here? There's no type of delivery listed. That's what's missing. So please make sure, and I saw a list today, missing deliveries. Please make sure that you list all your patients have deliveries listed. See if there's anything else. Here's another one of my favorite pet peeves. This person put previous CD, arrest of dilation. Now, the indication for a prior C-section is important when you're counseling the patient of their chances of success. But they're not going to say to you, well, what was the patient's prior C-section for? They may say to you something like, what are indications for a prior C-section that are more favorable for successful VBAC? So that's fair enough. You know, again, it's more of a general question than specifically necessarily about this patient. They're not going to say, you know, on the spot, calculate what this patient's chance of success for a VBAC is, as an example. Here's another example of the mild gestational thrombocytopenia I was telling you guys about. I don't know if you can see it, if it's big enough. But it doesn't matter. The topic's out there. We're either going to include it or not include it. I think those are all the examples I pulled up for you guys tonight.
I have a question.
All right, last call for, thank you. Go ahead, Carla.
So I have this patient, she was 39 and 6. In the antepartum column, don't really have any complications, but then she was found to have gestational hypertension. So I put it under the delivery/postpartum. That's fine, question mark?
Yeah, that's exactly right. So anything that occurs up until the time you write admit to labor and delivery should go in the antepartum. So if you saw her, you know, and she was in triage and you discovered her to be hypertensive at that time, that's where I'd list it. But if, let's say you admitted her, she's 39 and 6, you were going to augment her, she's maybe in early labor, and then, you know, 2 hours later you discover that she's, her blood pressure's going up and she's becoming hypertensive, then I would list it in the delivery postpartum column. So as soon as you write the order, anything that happens from there through the postpartum period really belongs in the delivery postpartum column.
Okay, sounds good.
Thank you. All right, guys, last call. Anybody have anything?
No, that was great. Thank you.
Yes, thank you.
Thank you, guys. Good luck with the submission, and I'll look forward to speaking with you next month. We'll do some mock orals and get on with the preparation. Have a good evening, you guys.
You too. Bye.
Right.
Thank you. Good night.